Hi. Okay, I have to apologize. Y'all, I'm flaked out again, but I will tell you this whole scheduled live thing going at a certain date at a certain time so that it is very predictable and easy for people to jump in is great. However, it is now summer and the kids are home from school and it is creating problems I did not anticipate. So I apologize that I had to move it from yesterday to today, but if you are here with me live, I am glad you are here. If you're watching this later, thanks for watching. If we haven't met yet, my name is Bree. I'm an RN, NP mentor, interview strategist, content creator, blah, blah, blah. I do a live, usually on Thursdays, while I'm getting ready for work. And I talk about all things nurse practitioner related, professional, hey Scott, professional stuff, clinical stuff, and I try and vary it up. So today we will be talking about procedures that an ICU APP, nurse practitioner PA, can perform. Because this is something that I hear from people not super often, but often enough that it makes me think it's not talked about enough. Particularly if you don't work in an ICU, you may have some misconceptions about what an APP can and cannot do. And it also varies for a lot of different reasons at all the different places you work. So I think there are a lot of options that we can do. And there are plenty of people who go back to school to be NPs or PAs, some type of advanced practice with the intent to be a proceduralist, with the intent to do nothing but procedures or work for a team that is heavily focused on procedures. And that's not something we tend to focus on talking about so much in the NP world. We tend to talk about the medicine of it and different aspects of that. But I think this is kind of important because for me, it's a good chunk of, well, I don't know. I would say almost every day I go to work, I do at least one procedure. So it's probably a good hour to a couple hours of my day every single day, depending on how the day goes. So people who are very rewarded by that enjoy working in environments where they get to do a lot of procedures. Some work sites you do, some work sites you don't. So I wanted to kind of run through this. I had this really kind of started because I had somebody DM me. Well, it wasn't actually a personal DM. It was in a forum where this was discussed, and then this person DM'd me afterwards. But there are a lot of people out there who think that ICU NPs can basically place lines and that's about it. There's a lot more that we are capable of doing. So I know it's kind of nuts, isn't it? I should probably, it's pulled back so they can get the makeup on, you know. Today's another reason it's weird is that I'm not going to work today, but it is my daughter's birthday. So I am getting ready to go out for her 12-year-old birthday party. So that's exciting stuff. Also, some housekeeping stuff. This summer is super weird because it's summer and I'm working nothing but days next week, so I will not be going live next week. And the week after that, I'm on vacation, and I haven't exactly decided how I'm going to handle that. So I apologize. The summer's going to get a little weird as far as showing up every single Thursday. I may move some days around, but I will make sure that I always put up a post on YouTube so that you guys know what's happening should you want to come on live. Yeah, so that's that. So procedures in an ICU. I think most people are aware of the standard stuff. Anything that involves vascular access, that is probably the commonest procedure that APPs do. Talking about arterial lines into the artery, which we'll do, you know, to measure blood pressure, to get frequent ABGs. Those are the two main reasons we would do that. But this is something that at a lot of places RTs will do. Some places I've worked before, and now this has been a long, long time ago, but nurses we wouldn't do the lines, but we were able to do arterial sticks for ABGs. At the place where I work now, nurses don't do it at all. But typically it's either going to be an RT yourself or a physician or a procedure team. So that's one of the vascular accesses. And then the most common one is going to be the central line. So the thing about it is there are a lot of different types of venous access central line types that are very similar. The procedure is all very, very much the same. It's all done under this technique called the Seldinger technique, which is where you put a needle in. We'll use an ultrasound. You put a needle in, you access the vessel, you thread a wire in through the needle, you take the needle off, and then you dilate, and then you put a catheter over the needle. So it's basically a catheter over a wire into a vessel. That is probably the most common procedure that an APP is going to do, whether it's into an artery or into a vein. but there are different things that you can thread over that wire. So when I talk about, central lines or vascular access, I'm really talking about a whole host of different things. Anything from central line, which have multiple ports that you can infuse medications through that are more caustic if they're given like peripherally, or to be able to administer some medications that you just truly cannot give peripherally. You can also draw blood from it. You just at the drop of a hat, you don't have to keep sticking people over and over for venous access for labs. So that's very helpful. There are also certain labs that you can get from an IJ central line that you can get from nowhere else. So those are all kind of the indications you would do a central line for vascular access to administer medicines, get particular labs that you can't get anywhere else. But beyond that, you can do a dialysis catheter in the same manner, a temporary vas cath. You can do something called an introducer, which is a large bore catheter. It's shorter and fatter. Central line is going to be kind of long. It's like, so you'll have different sizes, but which have to do with the lumen of the catheter, but you also have different lengths that go in different places. But you're going to anywhere from about 16 to 21 centimeters, depending on what side you go in and whether or not you're going in the groin or the neck, versus an introducer, which is going to be like 9 or 10 centimeters. And it's going to be super fat. It's fat and short, which is ideal when you want to give someone a lot of blood, when you want to resuscitate someone. So somebody who's bleeding, a trauma, GI bleed, this is someone you want to just stick that sucker in fast. They're designed to do really, really quickly and get that blood in quickly. So an introducer is another one, but is done basically the same way. What else do we do through the vein? Introducers. Oh, well, so the other thing an introducer will do, aside from allow you to have a short fat catheter to administer blood, is to basically act as a conduit to feed a different type of catheter through. So like a swan, a PA catheter, balloon pumps. As APPs, I don't know anywhere where mid-level providers are cannulating for ECMO, but this is done in a similar fashion. Scott, you do arterial sticks? Love it. Oh, I used to do them at Grady. I don't know why nurses can't do them at the place where I currently work. I'm not entirely sure what that's about, but I know there are plenty of places where they do. Yeah, it's kind of fun. It's sort of just a little different procedure, something different to do. Radial arterial sticks are kind of hard. Femorals are a piece of cake, but radials, they're a little on the hard side. Also, if you're just tuning into this, at the end, I am going to go over a few tips, like general type of tips for procedures that kind of range the gamut. So, I mean, you'll hear when we get there, but just FYI. So, I mean, you'll hear when we get there, but just FYI. Okay, so yeah, that was basically all I was talking about with as far as venous access. Sometimes you have to do a cut down. I've never had to do one of those. That is where you are not just utilizing an ultrasound, but you are literally cutting through the fascia and exposing the vessel to get into it. I've never had to do that, but I know that some vascular teams do that. And then that there are different site options for venous access, whether it's an IJ, a femoral, or a subclavian. All are different anatomical locations with a little bit different risks, but the same procedure: needle, wire, catheter. Needle, wire, catheter. It's all kind of the same. And then arterial sticks. Okay, and so then another procedure, and these are all procedures that are included in my credentialing packet. So I guess something I skipped over in the beginning is that the reason it varies with what you are capable of doing where you work is several-fold. First of all, you have to be trained properly. Secondly, you have to be credentialed by the hospital. And that means that when you go to work for the hospital, you can demonstrate to them that you have successfully performed a certain number of these procedures under guidance, and you are now capable of doing it independently. Independently meaning I'm doing it on my own in the hospital, but I need to have an attending somewhere nearby, somewhere in-house. It's not always like that, though. There are plenty of places where you go to work, maybe a critical access hospital somewhere at night, where you have an attending who is 10 minutes down the road. They are on call, but they are accessible. And this is kind of interpreted in different ways in different places, which is why you'll see different things. But so training, credentialing, the hospital board meets monthly, and they have to approve you to do all of these things. And if the hospital credentials you to do it, that means you have the blessing of the hospital to do it. It doesn't necessarily mean that you are skilled enough and safe to do it. It just means that you've demonstrated you've done enough proctored procedures. So again, this gets great. Like, I'm credentialed to do things that I am not skilled or capable of doing, or that I don't do often enough to really be truly good at. So like, for example, chest tubes, I don't do them often enough that I am personally comfortable doing them without an attending very near me, so that if I get into trouble, they're there with me. So it's going to be different based on where you go. The other thing that's going to vary things is the culture of the team that you work for. Even with the place where I work, different ICU teams function differently because the culture of their particular work group is such that they are empowered to do more, or they are asked to do less. Maybe not just because they don't feel like they're capable of it, but because there are residents or trainees that need to do them first, or because the attendings bill for them. So there are a lot of sort of behind the scenes variables as to why I can go to work at one place and do every single procedure, all the intubations and all the procedures and all the land, and go to another place and probably only be doing vascular access stuff. It just depends on where you go to work. So you have to be credentialed to do these things. One of them under my credentialing list is using ultrasound evaluation, a POCUS, point of care ultrasound evaluation. And that means evaluating everything from the heart, the abdomen, to the lungs, to the vessels. And this is a procedure per se. Yeah, I mean, it's considered a procedure. I'm credentialed to do it, but this is something you have to train up to as well. But this is something that you will see many teams doing frequently. They're going to pull that ultrasound in the room. Some teams do it every single day just to evaluate volume status. Some people do it during codes or when people are decompensating. It is a very useful tool, but it is a tool. I caution you, it is one tool. Is there a sign-off form signed by a doctor? Yes. So when you start, I think pretty much everywhere will require this, but you have to, at least the two places I have worked as an NP have both required it. Once you start, you'll have a provisional credentialing. So they'll say, okay, you're new, you have to demonstrate, depending on your experience level, right? If you're brand new, fresh out of school, and you've never done these procedures as an NP, even if you did them as a student, if you haven't done them as a paid NP, you'll be on a provisional basis. So they'll give you a list of however many procedures you need to do. You will perform it under supervision, and you will have the collaborating doctor or your NP sign it under the collaborator's name. And then you'll submit those, and then you'll be fully credentialed. And you have to re-credential every couple of years. When I went to work for another place and I had experience, I only had to do like 2. It was basically just somebody saying, hey, can you do this? And they watch me from the window. Okay, you're good to go. But I did have to get them signed. It's all the legalities of it, you know. So let's see, this is talking about the ultrasound things that you can do. Okay, so useful ways that ultrasound can help you. So probably one of the most common ways that we use an ultrasound device, I mean, is to help guide us in our procedures, particularly anything with a needle over a wire, but, or a wire over a needle, but looking at the heart. So cardiac POCUS, looking at all the windows of the heart, is very useful for a lot of different reasons. The most commonest thing you're going to see, though, is people looking at volume status. Are we seeing, what are the filling pressures looking like in the heart? Do they look empty? How does the pump look? Do you see any gross, like, in order to see a vegetation on a valve on a standard, like, bedside POCUS, it would have to be pretty egregious. Those suckers are really, they hide well. They're not easy to find. They're typically found on a transesophageal, not a transthoracic, which is what we'd be doing. But you can see gross abnormalities, so like a pericardial effusion. If you were worried, say you were in a code and you were worried the patient had thrown a PE, you can stick that probe on there real quick and see is the right side super dilated out. That might be concerning. Hey, Mr. Midwife, you're at work, you're watching. When I don't know what you mean by that. I'm glad you're here. What else? Yeah. Okay, all that. And then IVC evaluation, looking at volume status, is another way of looking at it. You can also look at the hepatic vein. That's another collapsible vein to determine whether or not you have, it can indicate that you have, that you're slightly hypovolemic and you will be volume responsive if we give you fluids. Pulmonary, looking at lung sliding for a pneumothorax, pleural fluid evaluation, is there enough volume to tap them for a thora, and a FAST, which is commonly used by our trauma teams, looking at all the parts of the abdomen. This is, okay, so FAST stands for Focused Assessment via Sonography in Trauma. And it's actually looking at all the different anatomical locations in which blood or injury can be occurring. And it goes through all of it, but we focus a lot on the abdomen because that's one of the commonest places that people bleed when they have blunt trauma. It's done very rapidly, part of the ATLS primary injury survey. Okay, so that's the ultrasound. Endotracheal intubation. Now, this one is interesting. This is not something you're going to see done at a lot of places. Many places, if you work in an ICU as an NP, you're not going to be intubating because they prefer that anesthesia do it. A lot of organizations want just the anesthesiologist, or the anesthesia team, I should say, to be the intubators. I've worked places where during COVID they had like a team that did it. And I've worked places where only physicians do it. Where I'm at, we're very blessed that my program was built by a cardiac anesthesiologist / intensivist, and it mattered to him that the NPs that worked there were trained up basically to his skill level. So he always taught them to intubate. So the culture of the place where I work has always been that NPs intubate. So if it's my patient and they're crashing, I tube them. Or like I'll help out too with other people. There's some people, well, anyway, I can intubate where I'm at. It's great. It is definitely a fun skill. I really enjoy it a lot. It's it's one of the most intimidating procedures that we do, but it's not the most technically difficult procedure that I do. So that's interesting. But it's probably the scariest. And I think the reason it's so scary is that if you think about the situation in which you're doing it, it's almost always in the ICU setting. It's rarely controlled. It's usually like an escalated problem or an emergent problem. And there's a lot of people in the room and they're all looking at you. So there's a lot of pressure. And you also know that you only have, minutes to do this. And so sort of a ticking time bomb. Like if you can't get it, what's going to happen? So a lot of study and work and effort and practice goes into learning how to intubate, how to mitigate risk, how to assess risk. But yeah, there are places where NPs can intubate for sure. Lots to see with the ultrasound. Granted, I'm not trained, but those images just like a mess to me. They do me as well. I am pretty good with most all of the ultrasound. FAST, I'm not going to look at the specialty teams and groups that do trainings on just cardiac, or not just cardiac, but ultrasound. They're super intense. I've never gone to one. I've always thought it would be cool to go one, but that is something to me. It's very right brain. It's just like x-rays. Like you can learn the theory of it, but honestly, you just got to get in there and do it. You just got to get in there and start looking at them, looking at lots and lots of hearts. And then eventually you'll start to recognize things by pattern. So yeah, I'm not the best at it, but I can do the basics. I can get the gist of it, But having said that, and I'm going to talk a little bit about ultrasound tips at the end, I think it's super important that as an APP, if you're going to work in an ICU, you learn how to use an ultrasound, even if you're not great at it. It is a very, very useful tool, and you really should have it in your toolkit. It is a very, very useful tool, and you really should have it in your toolkit. Okay, so... Okay, under the endotracheal intubation, I talked a little bit about, I don't know, just the different tools that we use, because there are different methods you can use to intubate people. Oh yeah, I forgot that when I wrote this, there was a great, okay, if you don't subscribe to get my emails, go to my blog and look at this one that I'm talking about, ICU Procedures, because there's a link to, I'll try and put it on here afterwards at the bottom of this one as well. But it's it was a great article that was written about the technical errors that tend to happen with intubation and how to avoid them. And a lot of it has to do with positioning and what blade you're using and the commonest problems that you'll come into when you can't visualize the cords. It was one of the most well-written I've read and like easy to understand. So I linked it there when I was kind of doing research for that. Bronchoscopy. So, this would be another one of those where I am in the pre-credentialing phase, and I've been stuck in that pre-credentialing phase for years because we just don't get enough of them. I work for a team that is like half pulmonology and half critical care. And so we just don't get a ton of bronchs. I should say this. There's a caveat to that. Bronchoscopy for an ICU NP is done for usually one of two reasons. The first one being you are assisting someone with a tracheostomy. So a physician who's performing a trach at the bedside is prepping, doing all the work here. You're sitting at the head of the bed, you've got the bronch in place, and you're inserting it, and you're just going basically to here. You may go in before they start and look at the various branches just to get a visualization, clear anything out, but you're not doing a full, exploratory, diagnostic, therapeutic bronchoscopy. It is just to assist with the procedure. I do that all the time. To me, that's very different than doing a full bronchoscopy. Like you have a patient who's mucus plugging, or you have a patient who needs exploration. That is a different animal. And to me, this is a very hard skill. I feel like people who are good at video games are good at bronchs. Because it's very much the spatial awareness thing. You've got to hold your hand up and at a certain angle, and you've got to know which way to turn it. You've got to know your landmarks very, very well because it all looks the same. Once you get down, say you're going into the main trachea, you hit the carina, and then you branch off to the right, and then you have all these various different segments branching off. Well, it's very easy to forget where you're at. And so you have to constantly come back up and find the carina and reorient. You have to memorize a lot of things. There's just a lot of technical difficulties to it. Like sometimes it's very hard for me to get up into the right upper lobe. I just cannot do it. So I don't gravitate towards the opportunity to do it. Should I want to, I could certainly push for it more and I would be fully credentialed for it. I just don't really want to. I don't love it. It's not something I'm particularly skilled at, but it is a good skill to have because if you run into a situation where a patient has a trach or is on a vent and there is a lot of secretions and they've plugged off, really, you can do a lot of like what we call deep NT suctioning. The RTs do, you go in with deep catheters, but you're only going to be able to get to like right here. You ain't going down into the lobes. So if you have a lung that's collapsed or something in the way, it is a useful resuscitation skill. So there's that. Emory has a team they are called interventional pulmonology, I think, or pulmonology interventionalist. But it is a physician, and when I was there, it was one APP. I think it's two now. And all she did was walk around doing bronchs and chest tubes and she was doing pulmonary procedures at the bedside to take the workload off of the physicians. So people like that will be doing that kind of thing over and over and over and over again. Hello, Aggie Blessed. Thanks for joining. We're talking about ICU procedures that NPs can do. The other reason in which you would do a bronchoscopy would be diagnostic in order to get a BAL. So say you have a patient who has pneumonia, they have a nasty pneumonia. You've not really been able to get a good specimen to culture, or you got a specimen and it was already it was sterile. You need something a little bit deeper down in the lung. And so you'll go in with your camera, do a rinse, lavage out with saline, and then suck up some of those good goobers, for lack of a better word. Again, you see why I don't love this? I don't love this procedure. It's gross. It's gross. And then, pulmonologists are going to do the more intense stuff. There's a lot more you do in bronchoscopies, but that's really more for the pulmonologist mindset. There are things called e-buses. There are rigid bronchs. There are things where they go in and take biopsies, put stents in. Those are really physician-led things. Now, having said that, if you worked for a pulmonology team strictly, you would probably be doing more of that, but that's like they would train you up to that. But you are absolutely capable of it. Chest tubes. So as I talked about before, chest tubes is a very, very common procedure that APPs do in the ICU. It includes two different types of chest tubes, and they are, to me, night and day different in the procedure. One is your small bore pigtail chest tube, which is basically the same kind of procedure as the intravascular access. It is a ultrasound, it is a needle, it is a wire, and it is a catheter, and it is small, and it goes in, and then you just hook up your little stuff on the outside, kind of piece of cake. Versus a surgical chest tube, some people will call it just a trocar, but it's a cut down. So you are cutting through the fascia, you are digging in there, you are inserting this tube. It is an open chest tube. It is a whole different ball of wax. We did a heck of a lot of those during COVID. In fact, that's when I got kind of fully credentialed with chest tubes, was during COVID. Prior to that, it was kind of hard to get them because these days most people gravitate towards a pigtail, but there are indications when you need a bigger chest tube outside of surgery. But there are reasons why you would need that at the bedside. And COVID was one of those. Pigtails, some of them, they just needed so much evacuation because the lung just turned into like mush. It just turned into like a sponge that got saturated and then sat out in the dry sun. It just like disintegrates. So the parenchyma was just a mess. They would constantly have pneumos and they were popping lungs all the time. So, I mean, I had a dude who had 7 chest tubes at one point in time. So got pretty good chest tubes during that period of time. Don't want to do that again. What do I think I'm going to do each day? Sorry, let me just take a minute and get that. Yeah, this one will work. Chest tubes aren't my favorite procedure to do, but you know, they need to be done. It's important. You need to get skilled at them. Most places will allow APPs to do this that I've seen. There's some procedures that I think, I don't know, the physicians tend to hang on to more, or they have special teams who do them. I don't know, but plenty of chest tubes get done. Lumbar puncture. Maybe you're gonna hear me say this on all of them. None of these are really my favorite. I am not really a proceduralist. They need to be done. And I remember when I was a new grad being super, super pumped about doing procedures, just getting in there and using your hands and doing this cool stuff. The further along I got into it, the less I was like, I could take it or leave it, you know. But LPs are hard. Now, I trained at Winship at Emory, and we did a heck of a lot of bone marrows there, and I didn't have problems doing it there. Because those patients were not in the ICU. Well, some of them were in ICU, but they weren't intubated, so they were able to sit up and lean over a table. And that position is completely different than an intubated patient that is on their side, that you're turning over like lateral decubitus, and you're shrimping them up, like you're touching their nose to their knee and opening up those spaces. And then you're not now going vertically, you're going laterally. It's hard. So of late, the LPs I've done, I think I've gotten 2 out of the last 10 I've tried. I have not been very skilled at them. And so I'm like, I can take it or leave it. I mean, I'll do it if you want me to, but I'm going to give it a couple efforts, and then it's going to be your turn to try. So I'm not usually raising my hand to try those, but it is something we can do. And if you don't have teams that do them, a lot of places have these patients go down to like an interventional radiology team to have it done, or they'll call a neurology team to do it. Then you may need to, because meningitis is bad, friends. Meningitis is bad. And meningitis is one of those very treatable problems that if you miss it and a patient dies from meningitis, it is a big time litigation lawsuit, because it's a real simple fix if you just knew it and treated for it. So you don't ever want to miss meningitis. So the rule of thumb is, if somebody comes in to the ICU and they are confused and they have a fever, think meningitis until you have another source. Sorry, I need to silence my phone. I have a group chat at work that is called Tiger Text, and so it has a tiger sound to it, because why not? But it is kind of obnoxious. Sorry. Okay. Yeah. So here's the thing, though. Sepsis, and this is what I deal with. This is my bread and butter, is sepsis. Almost always makes people confused. So confusion and fever alone doesn't mean you have to do one, but you need to have a pretty darn good idea of what is infecting them. If you don't, then you're going to probably have to do an LP. So it's useful to at least know how to do the procedure, or have a resource for someone who can do it for you, because you don't want to miss meningitis. There are other reasons you would do an LP, but this is the main one. This is the main one we worry about. Yes. Oh, okay. I'm sorry. Let me back up just a little bit on some of these. Scott said, lots to see with ultrasound. Granted, I'm not. Okay. No, I already saw that. Okay. Well, it is a restricted state. However, it doesn't really matter what state you go to. If you're working in-house in an ICU, you have to be credentialed. So you have to have a doctor cosign. Even if that doctor is not in-house, if you're in one of these teeny little critical access hospitals and where maybe it's nighttime and you're just covering the ICU and you do a procedure, there's still a doctor who's signing off on it. There is. We don't work truly independently in ICU. This gets weird, right? Because the board of nursings don't define these things well, but legally there is someone co-signing your stuff. Whether they are truly there or not is a different story. ICU, most of the in-house specialties, especially the more acute ones, they are all going to be a little bit more, you're going to require more oversight in those settings. Very, very different than if you're working outpatient and doing procedures. Very, very different. Is FNP allowed to work in ICU? This is a big time debate. I actually talked about this in one of the last live streams. I think, I'm trying to think what the title of it was. I think it was Where Can You Work Settings for NPs. The answer is yes and no, depending on where you are. Eventually, the LACE consensus model, which was a conglomerate of different NP organizations that came together and made recommendations for governing structure for NPs and work setting in 2008. And what they said was, this is when everything broke off. And so you couldn't just be an acute care NP, you had to subspecialize. So, and the reason is because they want the training to be directed to where you're going to be working. So as an FNP in critical access areas like the Midwest, areas where they cannot hire people, and some states that still haven't quite adopted the LACE consensus model yet, yes, FNPs can work in ICU. It will not always be that way though, because of this legislation, eventually they will not be able to re-credential, because when you go back for your re-credentialing at like year 5, you have to show that you have put in 10,000 hours of work time in the setting, caring for the population of patients in the role for which your certification is. As an FNP, you are a family nurse practitioner. You are treating patients across the lifespan. And yes, you can do acute. There is an acute portion of that. If you think about a patient coming into your clinic and they have an acute decompensation of their asthma, this is something you can treat in the clinic without having to send them to the hospital. So you have acute settings, but you're not doing actively decompensating dying patients. So it gets there's a lot of gray there. And you'll hear people staunchly say one side or the other, like, absolutely they can, or absolutely no, they cannot. And I talk to NPs across the country. So I know that there are places in the country where absolutely FNPs are still working in the hospital. But if your goal is to, like, if you know for sure you want to work in a hospital, just do your acute care, because eventually you're going to need to get that. Yep, there are some still. It depends on where you're at. It depends on all of those factors. There are some still, absolutely. Let's see. Bone marrow biopsy. Okay. I'm convinced this is the worst procedure you could do to a human being. It is absolutely awful. These patients are typically awake. They are laying prone. You have a literal Dremel drill in your hand and you are drilling into their hip. It's horrible. It seems like a super, to me, invasive procedure. I guess technically it's not, but it feels like it is. So I don't love it, but NPs can do this. I did it a lot when I was training, particularly if you're going to work somewhere for like a bone marrow transplant team, what I call liquid cancers is what Emory calls it. They have plenty of inpatient units that care for patients that are decompensating in that standpoint, and they have to do bone marrow biopsies. Suturing. So suturing, this is probably the most common thing that we do, because almost everything we do is going to involve some amount of suturing. I suck at suturing. It's hard. It's harder than you think it's going to be. But suturing, oh my gosh, you go to work in an ER, you're doing a heck of a lot of sutures. In ICU, we do this, every time that I put in a line, I've got to suture it down. If there is something that's bleeding, I'm going to suture it. If there is a catheter that was recently placed that's bleeding, I may have to do a special type of suture to get a little tighter closure on it. You will. Just wait. Scott said he cannot wait to suture. He's going to have so much fun doing it. You will. You will. Get plenty of opportunity to do that. There are other things that require credentialing that are kind of like, I don't know, they are procedures, but in my mind, they're not really procedures. And one of administering medications that are certain high-risk things, like intrathecal nimodipine. So in your neurocritical care units or your trauma units where you have an EVD, somebody who has had a seberac and they're prone to vasospasm, you can inject nimodipine directly into the brain through the EVD, and this requires credentialing. Same thing with like TPA Dornase, you're putting into a chest tube, into the pleural space because things are clotty and you just need to bust it up periodically. These are pretty straightforward. I mean, I say it's not really a procedure because it's like, once you know the steps, you just go in, clamp this, push the drug, wait a certain amount of time, clamp it. But I mean, that's it, really. It's not that super hard. But it is a credentialed procedure that is billable. Aggie says, Nurse Scott, you will get tired of doing it, especially in urgent care clinic in New York. I don't know. There are plenty of people who enjoy doing. So at the very bottom of this blog that I did, I linked a video where I interviewed my friend Jim, who is a new grad NP who went straight to work in an interventional radiology group. And he loves it. He does procedures from start to finish all day long. It is various different types of procedures. But some people really, really like it. I don't, but plenty of people do. And that segues into the next step, which was me talking about all of the different little types of procedures that are not common, but that need to be done. And in an in-house situation are probably going to be done by specialized teams or an IR team or an interventional pulmonology team. A lot of stuff you wouldn't think of. Fine needle biopsy of the thyroid. Gosh, what else? What else did I write down? I didn't write a bunch down. But there are a lot. He does a lot of different things. I mean, he's also going to do tunneled catheters of various sorts. They'll do drains of all types. They will biliary drains. They'll put drains in surgical, like next to where an abscess is, to drain it out. They do a lot of small bore and large bore chest tubes. They do lines as well. So a lot of little things that you wouldn't think of that you can do, but it's probably not generalized, not that every single ICU APP is going to be doing. Depends on the type of unit you go to work in. Oh, and surgical APP. So yeah, so if you work for a surgical team, and so some surgery APPs, okay, some of them only see patients on the floor. Some of them are in the OR and on the floor. Some of them are strictly OR. So like, for example, CT surgery, they tend to hire PAs because they want somebody who can harvest vein, and they go in for every surgery and they assist with every surgery and they do a little bit of management of the patient in the ICU. So some teams you may have more of a surgical focus than a medical focus, but it's a little bit of both. And they may do specialized things, like they may pull sheaths. They may do specific things that their team does. It's clear as mud, right? The whole point in this is to illustrate that it is more than just putting lines in people, which is what I think the common conception is. There's so many other things that you are capable of doing. A lot of it is just based on your training and where you work and what you're credentialed to do. So it's way more than just lines. Okay, so then I went on to talk about just general procedure tips. Let me put on some. Where am I at here in the process? Okay. All right, so the first tip, the best is you need to spend some time educating yourself on the ultrasound, which we kind of already talked about. But there's a lot of YouTube videos out there. There are a lot of courses you can take. This is not even so much applying it to the patient, but learning the knobs, learning the tool itself. This is not something I did, and I really wish that I had, because I feel like it would have expedited things a lot for me. If I spent just a little bit of time learning all the capabilities of the machine that I use, what it can do, it's more than just putting the probe on the patient. It's knowing which probe to use for what. It's knowing how to identify on the ultrasound to help you better identify those things. A color mode, a Doppler mode. There's a line that you can set on the ultrasound that is literally the midline. So you know if you see a vessel right here, we need to move it right here because we're right in the middle. And that line lines up with the little indicator on your probe. So if you go right there, you're going right there. Like just learning those kind of things and depth, gain, all of these things and how they help you to visualize what it is that you're seeing. I kind of wish I had spent some time doing that because these are things that I just acquired over time. Like I'd be doing something with another person like, hey, why don't you just try that? And I'm like, oh, I didn't know I did that. And I saw a physician where I work. This is how she does it. She does not let residents do any procedures until they undergo ultrasound training. And I think that's probably a good policy. So learn ultrasound. You're gonna need ultrasound for most all of the procedures you do to people. You're gonna need ultrasound to guide you. Try not to poke my eye here. Okay. Okay, and then, one of the best tips I have for procedures and I've seen one of my really good students did this too. You never know when a procedure is going to come up that you're not familiar with or that you haven't done in a long, long time. And it's just kind of sprung on you. Sometimes it's sort of emergent. You don't really have time to like stop and think about it. But what you can do is if you have saved resources on your phone, I have an app called Slidebox. And what it does is it allows you to sort pictures and videos into files so that you can quickly find them. And what I'll do is I'll find great resources. I'll screenshot them, have a picture of it, and then save it into that file. So if somebody comes to me and says, hey, I need you to do an LP or whatever, I can really, really quickly access those couple of screenshots that remind me what my landmarks are. Or I can quickly access the link to a YouTube that was, 5 minutes, just a brief overview of whatever it was I haven't done in a while. And do not be ashamed about that. I have heard almost every doctor I've ever known say, oh yeah, I will always go in a little room and turn on the video and watch it just real quick before I do it. There's no shame in that. That is making you a better provider if you are preparing yourself in advance. I think a lot of people see this as kind of a failure, and I would like to negate that. Sometimes just watching it done real quick refreshes your memory. But I had a student who did this, and I thought it was great. And I was like, you want to take 10 minutes and go find a video on whatever it is you're doing, and then we'll come back and do it. So this is a great tip for students. Save your resources in advance, like research what the common things are that would be done where you're going, and save your resources. And then that way, if you're stuck in a bind, if nothing else, you say, I'm gonna run to the restroom real quick. Everybody can take 5 minutes to the restroom, right? I'm learning a lot about ICU NP roll through you. Oh, awesome. Is it something you're interested in? I cannot remember. You're gonna have to remind me. I love it, clearly. Okay. What were other tips? This is another good one. Find yourself a mentor. I know this sounds pretty like asinine, like, okay, of course, Brianna, but no, really, find yourself a mentor. Somebody that you get along well with, that you think would be kind of more willing to teach you, and get to be their friend and literally just tell them. I find that, particularly when it comes to physicians, if you tell them what you need and they like you and you're easy to work with, they will spend time curating experiences for you. So if I really wanted to get trained up on bronchoscopies, I could go to some of my pulmonologists and say, hey, listen, I really need to get better at this. Can you help me find some? And they would call me and say, hey, yeah, absolutely. I didn't realize that you needed that still. Find yourself a champion who is willing to walk you through it, who you learn well from. And what will happen is they will preferentially get stuff for you, because the thing about procedures are you can research them, you can study them all day long, but it is just a hands-on thing. You just got to get in there and do them. The more of them you do, the easier it gets, just like everything else. And listen, you remember when you were a brand new nurse and you started putting in IVs and you were scared to death and you sucked at it And then it just got better. You just kept doing them and it got better. It is the same way with these procedures. They seem like they are a big deal. Okay, they are. Let me not undermine that. But it's just like learning any other skill. The more times you do it, the easier it gets. So you want to get as many experiences as you can. Okay, and then probably the most common thing, and I talked about this a lot, is the stuff surrounding a procedure, not just the technical skills of doing a procedure, all the things around it. So assessing risk. A big component of doing any procedure is assessing what your risks are. Knowing, why you're doing the procedure and what the potential pitfalls are. It's huge. It is absolutely everything. Because what I find as an APP, you'll get a lot of times is people will ask you to do procedures for them. Another team will ask you to do them, or another physician, or, somebody you work with, but they're just busy and you don't know the patient. And the thing is, if you don't know the patient and you don't understand, first of all, why you're doing it, what your placement options are, what the risks are, you're just going in doing something, and you can set yourself up for a world of problems. So the first thing what I commonly get is, hey, can you go put a line in on this person? This happens all the time. So the first thing I'm going to do is I want to know why. Are we doing this because we have no other access? Are we doing this because we need to, we are concerned that this patient could be in cardiogenic shock? Well, that tells me I want it to be up here and not in the groin, because I can't get a mixed venous from the groin. So what good would it be if I ran in and put something real quick like in the groin and it didn't get them what they needed? It's, versus like somebody who just needs a line because they're bleeding. Well, that might be the person I'm not going to put a central line in, but I'm going to put in an introducer. Also, knowing your site. So if this patient has a history of DVTs, or they have an active DVT, they've gone through all the workup and there is a DVT in the right fem, you don't want to put a line there. You don't want to put a needle in that. So you need to kind of spend a little minute or two looking through the chart or talking to the person to make sure that you know why you're doing it. The other thing is, if you understand, okay, so the patient who is a cirrhotic, they have high risk of bleeding. The patient who has low platelet counts is coagulopathic. This patient has a much higher risk of bleeding. So if you know that they have a diagnosis that lends itself towards more risk of bleeding, you're going to want to really look through their chart with a little bit more discretion. You want to make sure that you understand what you're getting into by putting a needle in this person. The other thing is, I want to know if this person is going to tolerate this procedure. So in the ICU, a lot of times people are intubated, but sometimes they're not. And in an awake person, if you say this was a cardiogenic shock, say this is a person that they're shocky, I don't know if they're septic or they're cardiogenic, I like to get a mixed venous. So they want something in the IJ. Okay. You go in there, it's a demented grandma and she's all over the bed. Well, now you're going to have to decide, okay, do I want to give her sedation, and what is the risk of the sedation in order to get this done, or do I just want to put it in the groin? So you have to understand the concepts or the reasons behind why you're doing it and what the specific problems are that you need to address. Sedation is always really tricky. So when you're going in to do a procedure, 9 times out of 10 as an APP, you're alone. I mean, by alone, what I mean is there's not a physician standing in the room with you. So if you go in there to do this and you may or may not have a nurse assisting you, and you have an awake patient and they're moving and you need to give them sedation, you're going to not only have to do the procedure, but you're going to have to monitor this patient. So it gets a little tricky. If you're going to have to give sedation, I always want to have a nurse in the room with me. It's not necessarily required. It's not typically considered conscious sedation until you combine both an opioid and a benzo. But you don't really know, right? For one person, you can give 1 milligram of Dilaudid and, 10 Xanax, and it won't be like a drop in the bucket. The next person, your little grandma, you might give 0.25 of Dilaudid to, and she stops breathing. So you don't exactly know what you're getting into. So I always like to, if it's going to be something I have to sedate, I always want a nurse on hand with me, just so that there are another pair of eyes on it. Because when you're in there, if it's difficult and you're looking and you're looking at the ultrasound, you're looking at the neck, the ultrasound, the neck, you're not looking at the monitor. So you need to have some help. Versus like, it's shift change. I just need a real quick introducer for a patient who is intubated that's bleeding a little bit. It's fine. I can run in there real quick, like stick it in the groin, no big deal, I'll be done in 10 minutes. I don't really need help for that. That's a different scenario. So it's looking at the reasons why you're doing it, the problems you're going to encounter, and mitigating that risk. So you want to know that. Let's see, you want to know about we already talked about bleeding risk. Bleeding is a big risk for most everything we do. So what is the bleeding risk? What are the platelets? What's the INR? If they have a higher risk of bleeding, like a much higher risk of bleeding, I am likely to go femoral only, because in the groin, I can hold pressure. I can hold pressure pretty much all day long. You can't hold pressure for too long here. So go in the groin if they're a big bleeding risk, unless you have issues. Like other things where you can't go in there because you've got a clot here and this side's got a balloon pump in it. Well, then you're kind of screwed. It's always a weighing of the risk benefit thing. Anatomical problems that make one side over the other, like a DVT, like venous strictures, okay, here's where a problem is actually a benefit for you. If you know you need to put an IJ on someone and they have a pneumothorax already on the right, go on the right, because you have no risk of dropping the lung. It's already down. Put it on the right. Sometimes it can work in your favor. And the last piece I talk about, and this is probably the most important thing, is you always want to know, you want to be acutely aware of what the potential complications are for what you're doing. So by understanding what the complications are, you can already be thinking through what your rescue strategy would be. And do you have the personal skill set that you can do that if you're alone, or do you have the in-house resources to do that if you can't? Because if you don't, you shouldn't be doing it, period. It should be delayed, or you should be bringing someone in emergently, depending on what it is and how urgent it is. But for example, my chest tube skills they're okay. They're up there, but they're not the greatest in the world. So if I went to work at a small little hospital where there's not a physician in-house at night, I'm probably going to be less prone to want to put something in the IJ, because my risk of pneumo on a tall, skinny dude, maybe with COVID, much higher. And do I have the skill set if I drop a lung that I can immediately put in a chest tube? You gotta think about those kind of things. If you cannulate an artery, so you put the needle in, you put the wire in, then you put the catheter in, and then you realize on the x-ray that it is in the artery. What is your backup? Do you have in-house vascular surgery? That is not something you should ever pull out, by the way. You leave it there and you let the vascular surgery team repair it. That's bad. So just understanding what the risks are with the procedures that you're doing, and then speaking through it with the patient. Has anybody consented this patient? Or are they leaving it all on you? Particularly if it's not your patient, right? Somebody asks you to do it for you, and you're like, well, did you consent them? What are you doing it for? All of these things should be considered. And that is it. There are plenty more procedures that we do that I just am not exposed to and not aware of. I mean, obviously, I only know what I know in my region of the world. So don't limit yourself to thinking that if you go to work in an ICU, you're just going to be doing lines. There are a lot of other options for things that you can do. Conversely, you may go to work for a team where they don't want you to do a lot of procedures, and that may be okay with you. It's just a part of what we do. I think it adds another layer of complexity. I think it makes us more marketable. I do enjoy having these skill sets, and I do sometimes enjoy doing these procedures. I was more excited about it in the beginning. I'll leave it at that. But there are plenty of people who just want to do procedures. They are much more like drawn to that kind of thing. And that is it, my friends. Let's see. So next week, I will not be doing a live because I have to work all days. The week after that, I'm going to consider moving it to a different day. I'm not entirely sure what day it will be because we're on vacation. It might end up being Friday of that week. And that we'll be talking about I can't remember its title, but it's a blog post I wrote on tips for helping you to find a clinical preceptor. I think that people are getting ready to go into fall semester. They're already getting ready to start that process and finding preceptors, because I've had people reach out to me. So I thought it'd be a good time to kind of address that. So I got some good tips for you. 2 weeks from today. I hope the clinicals are going well for you, Scott. I can't wait to hear you getting some suture skills in. Hope that y'all have a good week, and thanks for coming as always. I really enjoy seeing y'all here.